Genetics plays a role in the destruction of the beta cells in type 1 diabetes. And the second cause is environmental. Usually exposure to virus can result in damage to beta cells, bringing on type 1 diabetes. And you see the onset of diabetes in 12-year-olds around the age of 12. And most common in 12-year-olds. Clinical manifestations of type 1 diabetes, you're going to see the 3 P's, which is polydyspnea, which is increased thirst, polyuria, which is increased urination, and polyphagia, which is increased hunger. I always like to say poly is thirsty, poly want to drink, poly got to go to the bathroom, and poly wants a cracker. Usually have weight loss, fatigue. You usually see that in type 1 diabetes. And in type 2 diabetes, it's caused by impaired insulin secretion or insulin resistance. Insulin cannot be bound with special receptors, so insulin becomes less effective in stimulating glucose uptake and regulating glucose release. There must be an increased amount of insulin to maintain glucose levels at a normal or slightly elevated level. There's enough insulin to prevent the breakdown of fat and production of ketones. It's called uncontrolled type 2 diabetes, leads to hyperglycemia and hyperosmotic non-chaotic syndrome. And type 2 diabetes is better known as non-insulin dependent diabetes mellitus. Causes of type 2 diabetes mellitus, you usually see weight gain or obesity cause insulin resistance. You see inactivity, which causes a risk factor for diabetes type 2, which is a sedentary lifestyle. There's no exercise, resulting in insulin resistance and impaired insulin secretion. Clinical manifestation of type 2 diabetes are usually overweight. They have dyslipidemia, hyperinsulinemia, hypertensive. They usually have the 3 P's, polyuria, polydyspnea, and polyphagia. Just remember, for intake purposes, you will see polyuria, polydyspnea, and polyphagia on almost every question, but you want to pick the one that is most current to type 2 diabetes. And so you most likely want to stay away from the polyuria, polydyspnea, and polyphagia and go for another form of answer that's most closely related to type 2 diabetes. You will see fatigue, pruritus, which is itching, recurrent infections, visual changes such as blurred vision. You may have paresthesia or weakness. Signs and symptoms of hypoglycemia. Here I have a handout for you on hypoglycemia. Please for me. In hypoglycemia, the patient usually have nervousness, they may be sweaty, tachycardic, and they also may have irritability, headaches, loss of concentration, visual disturbances, dizziness, convulsions, coma, death, palpitations, tachycardia, restlessness, anxiety, tremors. That's just what you'll see with hypoglycemia. And how did we say, do we treat hypoglycemia earlier? We treat hypoglycemia by giving juice or feeding the patient a meal to bring up the blood sugars. Signs and symptoms of hyperglycemia. Usually in hyperglycemia, you will see polyuria, polydyspnea, polyphagia, fatigue and weakness, and vision changes. Usually, like I said, you usually see they want to go to the bathroom, they need water, they want something to drink, they want to eat, and they always feel tired and sleepy, really kind of drained. And how do we treat hyperglycemia? We usually treat hyperglycemia by using a rapid-acting insulin. It begins to work about 15 minutes after injection. Its peak time is 1 hour, and it continues to work for 2 to 4 hours afterwards. Examples of your rapid-acting insulins are Humalog and Novolog. They're known as insulin aspart. That's what we usually use to treat high glucose levels. Next is your short-acting insulin. Short-acting insulin is regular. It reaches the bloodstream in 30 minutes after injection. Its peak time is 2 to 3 hours after injection. It works well for approximately 3 to 6 hours, and examples are Humulin R and Novolin R. And next you have your long-acting insulins, which reaches your bloodstream 7 hours after injection and tends to lower glucose levels fairly evenly over a 24-hour period. Example of this is Levemir and Lantus, and better known as Detamir and Garden. You usually see those two that used to treat. Usually they're given, Lantus is usually given at night, and you really have to watch them, like they say. It tends to drop the blood sugar, so a couple of hours, usually 3 to 4 hours after giving Lantus, you really want to be watching your patients because they can drop really fast with the Lantus. And now we're going to move on to patient teaching. If you want to teach your diabetic patients, you want to teach them about foot care. You want to make sure they check their feet every day. You need to look at your feet every day for cuts, blisters, red spots, and swelling. You want to tell your patients that use a mirror if they cannot check their feet or see their feet. They can use a mirror after they get out of the tub to look at their feet, make sure they're not red, make sure there's no blisters or anything on their feet or cuts. And also they can wear white socks. You want to make sure they wash their feet every day. With warm water, not hot water, because due to the neuropathy, they can't tell if their feet is being burned. So you want to make sure that, you want to use kind of warm water. Some do not use real hot water. They want to dry their feet thoroughly and in between the toes to decrease their risk of getting breakdown on their feet. Also, you want to keep the skin soft and smooth. Rub a thin coat of lotion over the top of the feet, just to soften them up, to make them soft so they won't crack. Because if you have dry feet, they crack, it's going to make sores, and that's another problem for a diabetic. And next, you want to make sure you want them to smooth corns and calluses gently. Usually we tell them if they're having problems with their feet, they can use a pumice stone if the doctors tell them they can use a pumice stone, but we really don't recommend that. It's best to go to a podiatrist and let them help them with their corns or calluses they may be having. And if you can see and reach your feet or feel your feet, trim your toenails regularly. If you cannot, ask a foot doctor or podiatrist to trim them for you. I always want to tell them to file straight across, do not round. File straight across. But if they can't see their toes, and if their toes are brown and brittle, they don't want them to try to cut their own toenails. They want to go to a podiatrist for that. And you also want to tell your diabetics to wear shoes and socks at all times. Never walk barefooted. Wear shoes that fit well and protect your feet. Feel inside your shoes before putting them on to make sure the lining is smooth and there are no objects inside. And now we're going to do a case study. In this case study,
You can watch this presentation by eating.
in the case study, a patient is a 56-year-old male who has type 2 diabetes. He was first diagnosed with the disease at 12 years old. He's come to see his primary provider today because these past 6 weeks he's had numbness and tingling in both feet, extending from the tip of the toe to just below the ankles. For the first 4 weeks, these sensations were intermittent, but now they're constant. He states that he has occasional episodes of substernal chest pain, and these are brief and occur both at rest and when he's active. The patient is 5 feet 6, weighs 267, and his BMI is 43.1. Placing him in the category of obese. He is currently prescribed metformin, 800 milligrams twice a day. He's on hydrochlorothiazide 25 twice a day and lisinopril 5 milligrams once a day. He had been prescribed most postprandial insulin, but stopped taking it 8 months ago because he felt fine without it. His blood pressure today is 168/92. Aside from subjective complaints of numbness and tingling in both feet and chest pain, the physical examination and health history are unremarkable. The patient smokes 10 to 15 cigarettes a day. He does not drink alcohol, and he has a desk job. When asked, the patient is unable to name long-term complication of diabetes, and although he knows that high serum glucose is not good, he does not know why. He has not spoken in depth about the disease with a healthcare professional for several years, and he last saw a PCP on 14 months ago. The patient cannot remember when he had an eye exam in the past several years, and he confesses that he never examined his feet and does not take any special precautions to protect them. He occasionally skips his metformin doses and is antihypertensive, and never exercises, and measures blood glucose 2-3 times per month. Although his primary care provider has offered the patient consultation with a dietitian, a physical therapist for an exercise program, an appointment with a smoking cessation program, the name and address of diabetes support group, the patient has not yet followed up with these providers. The patient is married, and according to the patient, his wife thinks he looks fine, and he does not understand why, if a patient is relatively happy with his current state of health, he needs to take all those medications. So we're looking at Mr. This male here, he's 56, his hemoglobin A1C is 9.4, his glucose today is 219 while he's in the office. His serum cholesterol is 199, his bun is 24, and his creatinine is 1.9, and the estimated renal function is 58.6. So, and look at this case study. This 56-year-old man is classically non-compliant with his medication and meds because of his lifestyle of being overweight. He has a desk job, he's not getting much exercise, and the fact that he's a smoker puts him at risk for diabetes and having complications with diabetes, such as having, because of hypertension, having renal failure. He might end up on dialysis. It puts him at risk for losing a limb or peripheral vascular disease due to the high blood sugars. Not controlling those causes small and large vessel damage. So in this case study, we know that this patient is non-compliant, so he really needs a lot of teaching. And also we need to bring in his wife for teaching too, because she is saying that he's fine when he's a diabetic and not worried about it, but she needs to understand that because she is probably the one who cooks at home and prepares the meals, and she needs to encourage him to eat his foods correctly and stay on his 1888 diet, whatever diet the doctor prescribed for him. And also to check his blood sugars regularly, at least 3 times a day and not 3 times a month. And this concludes our teaching for today on diabetes. Hope if you have any questions, you can ask me after class, and I'll try to clear them up as much as I can. Good day.
Are you finished?